Remember, when we see a new drug, we want to use a drug because it's clinically different. It does something that we couldn't do to patients before. It makes them live longer, makes them live better. It reduces a side effect. And to discover that, we need clinical differences, which we discover through properly powered and run clinical trials. When we want to make a new version of a drug, we want to know how same it is, how similar. And what the regulators tell us is that the best way to discover whether version A or version B of a drug is different is analytics. They tell us that you can discover anti-drug antibodies at a level more than 1,000 times more dilute than you'd ever pick up with a clinical problem through analytics. That's the power. So step by step, they use perhaps 60 to 100 critical attributes of the drug to demonstrate sameness or difference. Let's talk a bit about equivalence, because this is a statistical endpoint that we're not used to in conventional trials. When we have a new drug, we want to show it's superior in some way. It has a difference that we can't explain by chance. It's more active, it has more tumour shrinkage, it has more survival, it has lower side effects. And so we power trials for clinical difference, and we look for an endpoint of clinical difference. When we power a trial for sameness, we look for equivalence. Now, that's new to us, but we generally explain equivalence as showing no meaningful differences in the clinical outcome. So that's based on looking at all the different trials. So for example, if you looked at trastuzumab, the monoclonal antibody we use against the HER2-overexpressing high-risk breast cancers, will show that each trial shows a roughly similar outcome. It reduces the hazard ratio of relapse, of death, by around 0.6 to 0.7. That's the ballpark. No trial will be identical, replicated in the next group of patients. We treat patients, they all have variability. But that variability decides what is the appropriate equivalence. And that trial design will be agreed with the regulator before it starts. And then at the end, we'll read an equivalence trial that shows no difference. These trials look different. They seem to be powered differently to our trials for superiority of a new drug. And when this whole pathway started a decade ago, and there was uncertainty about whether analytics were truly powerful enough to make that decision, the first generation biosimilar drugs came out with a requirement for something called a post-authorization safety study, a PASS, a PASS study. Now, we know as the clinicians, we know that as a phase 4 study. It says when the drug is licensed, does it really behave in big numbers in the real world in the same way as the original drug? Very importantly for us clinicians, these recruited large number of patients in real world scenarios, and every single PASS study of the first generation biosimilar drugs met their objectives. That's important to us. It tells us that the European regulatory pathway is robust enough to deliver drugs based on analytic similarity that perform well in the real world. Tellingly, the American Foods and Drugs Administration, which licensed their first biosimilar only recently, they came a decade late to this, have decided that the proof of principle is taken, that no longer will they require formally to have a PASS study for a new biosimilar because it's proven that the regulatory pathway works.